all safe, and I hope that one day will come when we will have lecture in our lecture halls. Let's pray for that time that all this pandemic is gone and we all have lectures in the lecture halls so we can interact also and we can uh, get more benefit from the lectures. So Bismillah Rahman Rahim. Today we will discuss the benign conditions of the uterus, which are Asherman syndrome, endometrial polyps, and adenomyosis. So we'll discuss one by one. So the learning objectives of today's talk are to describe the common benign conditions that affect the uterus according to the tissue of origin, the cervix, endometrium, and the myometrium. So the benign conditions which I already told you, the Asherman syndrome, polyp, and the adenomyosis. Understand the presenting symptoms and examination findings associated with these pathologies. So you must be able to understand the symptoms associated with each condition and their positive findings. To describe the common tests used to evaluate the uterus and endometrial cavity. So you should be able to enumerate the common tests which can be used to evaluate these different benign conditions. To explain the available treatment options for these benign conditions. So you also should be able to explain what are the treatment options which are available for these conditions. Now, Asherman syndrome is an infrequently acquired uterine condition characterized by the bands of fibrous tissue, that is scarred tissue, inside the uterine cavity or endocervix. It is usually secondary to intrauterine surgery or infection. The incidence seems to be significantly influenced by the number of miscarriages performed, the high incidence of genital tuberculosis in some countries, like our country, we have very common tuberculosis, and the different criteria used to detect intrauterine adhesions. Asherman syndrome is thought to be underdiagnosed because it cannot be diagnosed clinically. It needs investigation, that is hysteroscopy, because it is usually undetectable by routine diagnostic procedures such as an ultrasound scan. Or intrauterine myomectomy, cesarean delivery, or hysteroscopic procedures, metroplasty, uterine artery embolization, or pelvic radiations. These are the causes which may damage the stratum basalis of the uterine wall. Second cause is infections, endometritis. due to genital tuberculosis or schistosomiasis or any other kind of infection which may lead to endometritis. The third reason may be hypogonadism. Although not clearly identified, a possible genetic factor could explain why frequent adhesions, incidence, and recurrence, or why intrauterine adhesions can develop even without any surgical trauma or trigger event. So there may be a possibility of genetic factor in such cases. Uh, there are different types of Asherman syndrome according to the site of the lesion. Intrauterine fibrosis without visible adhesions or obliteration of the cavity, that is endometrial sclerosis, or adhesions only in the cervical canal, or uterine cavity adhesions involving central adhesion without obliteration of the cavity, or partial obliteration and constriction of the cavity, and last of all, complete obliteration of the whole uterine cavity. And the fourth one is the uterine cavity combined with cervical canal adhesion. So both uterine cavity and the cervical canal endocervix, they are all blocked due to adhesions. This is normal uterine cavity, normal uterus, and this is the normal uterine cavity. You can see it's all empty, there is nothing inside. And this is the endocervix, this is also all clear. While this is Asherman syndrome, you can see endocervix is clear, but there are these fibrous bands inside the uterine cavity. So these are the interuterine adhesions called Asherman syndrome. Again here, this is normal uterine cavity, all clear. Why? This is the Asherman syndrome. You can see these fibrous bands which are running from this wall to that wall, and they are obliterating the uterine cavity. So this is diagnosed as Asherman syndrome. Again, the different types. This is normal uterus, normal uterine cavity, and a cervical canal, nothing inside. While in this, there is endocervix is involved and there are adhesions in the endocervix. Here, there are central adhesions without obliteration of the cavity. And here, partial obliteration and constriction of the cavity. And here, there is complete obliteration of the uterine cavity. The whole uterus is obliterated. And the fourth one, it has both obliteration of the uterine cavity and the endocervical canal. So how can we diagnose Asherman syndrome? It cannot be diagnosed simply by clinical presentation or by pelvic examination, bimanual pelvic examination. It needs investigation, and these investigations involve the direct visualization of the uterine cavity, that is by hysteroscopy, which is the most reliable method of diagnosis. Other methods include hysterosalpingogram, in which we inject the dye through the cervix, and we take X-rays 5 minutes apart, two films. And this dye, radio opaque dye, it will pass through the uterine cavity into the fallopian tubes and will spill in the abdominal cavity. And while through passage, it will make opaque shadows in the uterine cavity and into the fallopian tubes. If there is any filling defect, it means there are adhesions. The other method is sonohysterography with 3D or 4D ultrasound. And last of all, MRI can be helpful as a supplementary diagnostic tool. It's very expensive and not available everywhere, so it is used very rarely. The diagnosis cannot be made with the fibrous band which is present in the Here you can see hysterosalpingogram. This is hysterosalpingogram showing the uterine cavity. The dye is injected through here from the cervix. This is the uterus. These are the fallopian tubes, and this is the spill of the dye into the peritoneal cavity. So the dye injected over here, it causes radiopaque shadows outlining the uterine cavity. But here, this is the filling defect. Here also, this is the filling defect. So this filling defect shows that the presence of adhesions at this place. So it means there is intrauterine adhesions present in the center of the uterine cavity, while the rest of the cavity is patent. The dye goes from here into the fallopian tubes and spills into the peritoneal cavity. Like this, similarly on this side, the tube is outlined and this is the spill into the peritoneal cavity. This is another hysterosalpingogram showing filling defects into the uterine cavity. These are the filling defects into the uterine cavity. The uterine cavity is not properly outlined. So this shows this is also presence of intrauterine adhesions, Asherman syndrome. Again, you can see the whole cavity of the uterus, but there is filling defect in the cervix. So this is endocervical canal where there are presence of adhesions causes filling defect over here, while the rest of the cervical canal is patent. So these are the fallopian tubes and spill of dye into the peritoneal cavity. Again, this is another picture, X-ray of the hysterosalpingogram showing filling defects. These are these black areas. These are the filling defects of the radiopaque dye, which shows that adhesions are present at these places, while the rest of the uterine cavity is patent. So this is uterine cavity, and these are the filling defects showing presence of intrauterine septas. Now, how can we manage as there are presence of intrauterine adhesions? So we have to remove these intrauterine adhesions, and the most the gold standard for this Asherman syndrome is hysteroscopic resection of these intrauterine adhesions, or the old conventional method is dilatation and curettage of the uterine cavity and adiosolysis of the intrauterine adhesions. So re-adhesion prevention, after this hysteroscopic resection of the intrauterine adhesions, there are certain steps which we can take to prevent further formation of adhesions, re-adhesions. These are intrauterine device. We can place a copper T inside the uterine cavity. So it prevents the further formation of re-adhesions. Or in a uterine balloon, stand Foley's catheter, or anti-adhesion barriers, that is hyaluronic acids. There are hyaluronic acid gels. If they are inserted inside the uterine cavity, they will prevent the formation of adhesions. Restoring the normal endometrium. So we have to give hormonal treatment or stem cell therapy so as to regenerate the epithelium. Post-operative assessment to see whether the surgery is successful or not, we have to do diagnostic hysteroscopy or ultrasound. This is how we do. This is the resection of the intrauterine adhesions, dilatation and curettage. These are the adhesions. They are resected with the help of a hysteroscope here. This is the scissor, which is introduced by a hysteroscope, and these adhesions, they are cut with the scissors. And after this adhesiolysis, we have to insert intrauterine contraceptive device for a period of 3 months so as to prevent the re-adhesion formation. So this is how we treat Asherman syndrome, or we may give estrogen hormonal therapy so as to regenerate the epithelium. A stem cell therapy. This is the benefit of stem cell therapy. The endometrial cells, they have a power to regenerate. So stem cells, they are inserted into the uterine cavity. What they cause? They cause production of new cells, enhancement of the endometrial glands, reduction of the fibrotic tissue, secretion of the trophic factors like angiogenesis, activation of endogenous cells, and immune modulatory effects, and they cause inhibition of the cell necrosis and cause self-replication. So when immune modulatory effects, they are stimulated, they cause upregulation of anti-inflammatory cytokines such as interleukin 2, interleukin 4, and interleukin 10, and downregulation of pro-inflammatory cytokines such as interleukin 17 and tumor necrosis factor. So this is how the stem cell therapy works. So all clear that Asherman syndrome, that is intrauterine adhesions, they are treated by resection of the intrauterine adhesions via dilatation and curettage or by hysteroscopy. And after adhesive lysis, we have to insert an intrauterine contraceptive device and give hormonal treatment for a period of 3 months, so that there is prevention of re-adhesion formation and for the regeneration of the endometrium, damaged endometrium. And we can also give stem cell therapy, which will cause a regeneration of the endometrium. Now, uterine polyp or endometrial polyp. What do you understand by a polyp? Polyps, these are the localized overgrowths of the endometrial glands and stroma projecting beyond the endometrial surface. So peak incidence is at the age of 40 to 49 years of age. Cause is unknown, but they are more commonly seen in post-menopausal women who are on HRT and in the patient who are taking tamoxifen for CA breast. These polyps are mostly asymptomatic, mostly are detected by ultrasound. Now you can see over here the polyps. This is the uterus, this is cervical canal, and this is vagina. These are the tubes and ovaries. This is endometrial cavity, and you can see these projections of the endometrial glands and stroma, which are projecting beyond the endometrium. So these are the polypoidal growths, the endometrial polyps. These are the cervical polyps. This is cervix. When you put a cuscus speculum into the vagina, you will visualize the cervix like this. And this is the cervical os. And these are polypoidal growths projecting outside through the cervix. So these are cervical polyps. These are pedunculated. They have a pedicle. These are pedunculated cervical polyps. Again, this is a cut view, cross-sectional view. This is cervical canal. This is vagina. You can see the rugae of the vaginal wall. And these are the cervical polyps, which are originating from the cervical canal. The stalk is attached to the cervical canal, endocervix. Here, again, you can see the stalk is attached over here, this point. And they are protruding outside the cervix. So these are the cervical polyps. So these polyps, they may be pedunculated, as I told you, or sessile. The size is 1 millimeter, or they may go up to 4 centimeter. They may fill the endometrial cavity and project through the cervical os. They may be single or multiple and may originate anywhere, but most commonly they arise from the fundus. So these are the pedunculated polyps. You can see they have a stalk. They are attached over here. So these are pedunculated polyps. This is sessile. They have no stalk. They are directly attached to the endometrium. So this is sessile. These are two sessile polyps. While this is pedunculated, this is pedunculated cervical polyp because this is the cervical canal. It starts from here and ends over here. So this is a cervical polyp which is pedunculated. So we have two types of polyps, sessile. These are sessile or pedunculated like this. So on ultrasound, what you will see, they may appear as non-specific echogenic thickening, round echogenic mass in the endometrial cavity. So they will show as an echogenic mass, better appreciated with fluid in the endometrial cavity. If you inject fluid into the endometrial cavity as in sono intrauterine, saline intrauterine sonography, when you inject saline into the endometrial cavity, then they can be clearly appreciated. They may be broad-based, short stalk, or they may be pedunculated, long stalk. So positive pedicle artery sign on the color Doppler. If you do Doppler study, there will be uh, you can see the blood flow into the stalk of the polyp. So regarding symptoms, most of the polyps, they are asymptomatic. They may cause uterine bleeding. It could be intermenstrual bleeding. It may be menorrhagia. It may be postcoital bleeding or postmenopausal bleeding. So these polyps, they may lead to menorrhagia, heavy menstrual bleeding, spotting in between the periods, that is intermenstrual bleeding, or postcoital bleeding. If it is a cervical polyp, it will bleed when there will be a intercourse. So what are the risk factors which contribute towards the formation of these polyps? Obesity, late menopause, partially estrogen agonist tamoxifen therapy. If a patient is on tamoxifen for CA breast, they may have increased chances of developing polyps. Or if the patient is postmenopausal and is taking a hormone replacement therapy, because the estrogen in the hormone replacement therapy, it will cause overgrowth of the endometrium and it will lead to formation of the polyp. So endometrial polyps, sometimes in 10 to 25% of cases, they contain hyperplastic foci, and 1% is frankly malignant. So whenever there is a polyp, we must do histopathology to rule out malignancy. So diagnosis, how can we diagnose? If it is a cervical polyp, it can be diagnosed clinically on post-vacuum examination. You can directly visualize the cervix and can see the polypoidal growth protruding through the cervix. But if it is an endometrial polyp, then we have to do investigations like ultrasonography, TVS, outpatient hysteroscopy, OPH, or saline infusion sonography, in which we inject a normal saline into the uterine cavity and then we do ultrasound, 3D or 4D ultrasound. Then we can see there are echogenic foci inside the uterine cavity. So this is hysteroscopy. This instrument is an hysteroscope which is introduced through the cervix and via the cervix into the uterine cavity. This is fiber optic, flexible hysteroscope, and it will visualize the uterine cavity directly. You can see from here, you see the this is the eyepiece, and you can see the inside of the uterine cavity, or you can also see the video. This is close picture hysteroscope inside the uterine cavity, and this is the endometrial polyp projecting through the fundus. So on hysteroscope, you will see the polyp like this. This is the polyp inside the uterine cavity. This is the hysteroscopic view of the polyp. This is uterine cavity. This is the tubal ostia. And this is the polyp which is attached to the endometrium over here. So this is the sessile polyp. It has no stalk. So this whole white egg-like thing is a polyp, endometrial polyp. So this is hysteroscopic view. So whenever you find you have a patient with polyp, how you will treat? The aim of the treatment is to alleviate her symptoms, that is amenorrhea, intermittent bleeding, postpartum bleeding, and optimize the fertility and exclude hyperplasia or cancer, because I told you there is 1% chance of malignancy, because 10 to 25% of these polyps they have hyperplastic foci. So this is the aim of the treatment. Now the treatment options available are polypectomy under general anesthesia. We give general anesthesia and do DNC polypectomy. We remove the polyp, avulse the polyp with the help of a sponge holding forceps, and then we curatize the uterine cavity to curate the base of the polyp and send the specimen for histopathology to rule out any malignancy or hyperplasia. And the most favorable treatment or the most definitive treatment is hysteroscopic polypectomy under local anesthesia. The polyp is removed by scissors or electrodes or by accelerators, and it is sent for histopathology to rule out any malignancy or hyperplasia. So this is how you will treat a polyp with the old conventional method, DNC polypectomy, or hysteroscopic. If the facility is available for endoscopic surgery, then you can do hysteroscopic polypectomy under local anesthesia. It can be done on outpatient basis. Under local anesthesia, we will introduce a hysteroscope inside the uterine cavity, visualize the polyp, and we will cut with the help of a scissor or mouse accelerator. So this is the hysteroscopic view of the inside of the uterine cavity. This is the polyp, pedunculated polyp. And this is the resectoscope, which is introduced via hysteroscope to cut the base of the polyp. So the base of the polyp is cut with the help of this resectoscope, and here the polyp is removed from its side. So these are the tubal ostia, fallopian tubes, opening of the fallopian tubes into the uterine cavity, and the polyp is gone, and you can see the clear uterine cavity. So this is how you do hysteroscopic polypectomy. Now, adenomyosis. What do you understand by adenomyosis? This is a benign condition of the uterine wall that occurs when the endometrium grows in the other part of the uterus. That is, there is growth of the endometrium into the myometrium. As you can see over here, this is endometrium and this is the myometrium. So this endometrium, it grows into the myometrium. These glands and stroma, they go into the myometrium and they form adenomyosis. This is presence of glands and stroma inside of the myometrium. This is adenomyosis. That ectopic endometrium is present in the myometrium. This is a healthy uterus, uterine cavity, normal myometrium. While here you can see this is uterine cavity and this is the myometrium, but it contains the endometrial tissue. And these are the lakes of blood in the myometrium, which are the endometrial glands filled with blood. So this is adenomyosis, which is an enlarged uterus. Uterus is enlarged by the growth of the endometrial tissue into the uterine myometrium. This means that the lining of the uterus grows into the wall and muscle of the uterus. So it has close clinical similarities with leiomyoma, that is fibroid uterus. It is mainly confined to the body of the uterus, occurring as discrete lesions or more extensively. It is rarely seen in the cervical part, so the uterine body is, in majority of cases, is involved. It is considered as an extension of the endometriosis, wherein the endometrial glands grow inside the uterine vasculature. It is a disease of multipara and seen mostly after 40 years of age. And overall incidence is about 10%. So adenomyosis is a disease of multipara. Okay, so you must, whenever you are given a scenario with multiparous patient and enlarged uterus, uniformly enlarged uterus, you must consider adenomyosis. Occurrence is more likely to be seen in women who are parous, as I've told you, multipara, and who have had termination of pregnancy. They have history of any previous DNC, spontaneous miscarriages, and endometriosis. So, you can also take the history from the patient, whether she had any DNC for any miscarriage or she had any spontaneous miscarriage, then it will be helpful in the diagnosis. How the patient will present with adenomyosis? She may have heavy menstruation, prolonged heavy menstruation with the positive clots, menorrhagia, severe cramps or pricking pain during menstruation, that is, she has severe dysmenorrhea, which continues throughout menstruation, abdominal pain, she may have backache, painful coitus, abdominal pressure if the uterus is enlarged up to 12-week size, abdominal bloating or nausea and vomiting during periods. So this picture you can see, this is endometrium and this is the myometrium. So these are the endometrial deposits inside the myometrium, while these are the fibroids. These are the fibroids, that is fibromyomas. These are fibroids. But adenomyosis, these are the lake of blood. These endometrial glands filled with blood because they respond cyclically. These endometrial glands, they will respond cyclically to the hormonal stimulation. So what were the symptoms? Menorrhagia, severe dysmenorrhea, pain, abdominal pain, backache, dyspareunia, abdominal pressure, abdominal bloating, and nausea and vomiting during periods. Again, symptoms, heavy menstrual bleeding, intermenstrual spotting may occur or postcoital bleeding. So why there is menorrhagia? The reason is there is increased surface area due to enlarged uterus, increased vascularity to support the enlarged uterus, and impaired contraction due to glandular tissue in the myometrium. The probable association of endometrial hyperplasia. So these are the reasons for heavy menstrual bleeding. So what are the causes which lead to adenomyosis? There are several different theories available that actually state the cause of adenomyosis. Among them, we are here to describe some to enhance your knowledge. If there is, during childhood, there can be a growth of extra tissue within the uterine wall, or the growth of stem cells in the uterine muscle wall, or invasive growth of abnormal tissues from the endometrial cells due to cesarean delivery. So during cesarean delivery, there may some endometrial tissue may deposit in the myometrium during surgery, which will lead to formation of adenomyosis later. Or other uterine inflammation after childbirth, they may lead to formation of adenomyosis. You can see this picture. These are the endometrial tissues inside the myometrium. So this is adenomyosis. The uterus is enlarged, boggy, due to the presence of these lake of fluid, and it is tender also. So how we can diagnose? So we can diagnose on clinically on examination. It is difficult to differentiate from fibroid when the uterus is uniformly enlarged. When it is uniformly enlarged, it's difficult to diagnose. The enlarged uterus rarely exceeds 12 to 14 week size. So in adenomyosis, the uterus may become enlarged up to 12 to 14 week size of the uterus. And it is tender on touch and it is boggy, soft. Enlargement of the uterus is regular in adenomyosis as compared to the nodular enlargement of the uterus in fibroid. So this is the differentiating point with the fibroid uterus. Then ultrasound examination is helpful when the adenomyosis is localized, showing hemorrhage-filled distended endometrial glands, and sometimes gives irregular nodular appearance as in fibroids. So the third investigation is MRI. It is expensive but excellent images if you have any uh, ambiguity or if you have any suspicion. Now how you will manage? As adenomyosis is a disease of multipara, it usually presents after 40 years of age. At this time, the patient has usually completed her family. So what happens? This the main symptom of adenomyosis is menorrhagia and heavy menstrual bleeding. If the patient is less than 40, we can give her medical management to control her bleeding with tranexamic acid and mefenamic acid. And for dysmenorrhea, we can give non-steroidal anti-inflammatory agents. It will cure both menorrhagia and dysmenorrhea. But for the cycle regulation, for lesser blood loss, we can give hormonal therapy. Hormones include, if the woman is less than 35 years, then Ozapis, and if it is more than 35 years, we can give progestogens. Progestogens can be given in the form of oral or implants, that is levonorgestrel intrauterine system and Depo-Provera injections. So these are the progestogens which can be given, which are long-acting reversible contraception, which is Depo-Provera, which is given a period injection. IM, methotrexate injection is given IM for a period of 3 months, and it is repeated for 3 months. After 3 months. And levonorgestrel intrauterine system, which is inserted into the uterine cavity, and it is also for a period of 5 years. That is Mirena. So this is the medical management. And the other treatment option is GnRH analogs, but are given for a short term. It will reduce the symptoms of adenomyosis and the size of the uterus also. But they are given for a period of short term because long-term use may lead to menopause because they are create hypoestrogenic state. So if we the main aim of the medical management is to induce pseudomenopause, that is, give the hormones continuously so as to create amenorrhea. Whenever there will be a amenorrhea, it will lead to the necrosis of the endometrial tissue into the myometrium. And there will be no bleeding in the endometriotic tissue, and there will be no pain, and it will also decrease the size of the uterus also. So it will cure both dysmenorrhea and menorrhagia. So this is the main aim of the medical management, to induce pseudo-pregnancy, amenorrhea. Now the surgical management, which is the definitive management. This is the definitive treatment for adenomyosis. If the patient is above 40, completed her family, she is multiparous, then she should undergo hysterectomy. Hysterectomy is the definitive treatment. It will cure her for lifelong. But if she wants to conserve her uterus and she refuses hysterectomy, then we can do hysteroscopic resection of the superficial adenomyosis. If it is less than 1 millimeter of myometrial invasion, then we can do hysteroscopic resection in such cases if the facility is available of endoscopic surgery. So regarding adenomyosis, there are two treatment options, either medical management or surgical management. In medical management, you have to give symptomatic treatment, which includes tranexamic acid and mefenamic acid, to treat menorrhagia and dysmenorrhea both. Or we can give hormonal therapy. Mainly progestogens, they are administered, and they are administered in a continuous fashion so that to induce amenorrhea. So if we are giving oral progestogens, they are given continuously without any break. So they will induce necrosis of the endometrial tissue in the myometrium, and it will induce amenorrhea. Or we can insert Mirena, liver nodular intrauterine system, inside the uterine cavity. It will also cause atrophy of the endometrium and endometrial tissue into the myometrium, and it will lead to amenorrhea ultimately. Similarly, Depo-Provera injections, these are also long-acting reversible contraception. These are the injections of metaxyl progesterone acetate. They are given intramuscularly after every 3 months, and in the long run, they will also induce amenorrhea. So the purpose of medical management is to induce amenorrhea so that the ectopic endometrial tissue, it dies out, it undergoes necrosis. So this is the main of medical management. So this medical management is only given in those patients who do not want to do, who refuses surgical treatment, or who do not want hysterectomy, or who are younger, or they want to retain their uterus, or they want more fertility. The surgical management includes hysterectomy and hysteroscopic resection. So hysterectomy is the definitive treatment in adenomyosis because mostly the adenomyosis is seen in multiparous above 40 years of age. The patient has completed her family. So the best treatment option is hysterectomy. Or if the patient refuses hysterectomy, then we can do hysteroscopic resection of the superficial adenomyosis if the myometrial invasion is less than 1 millimeter. So these are the treatment options which can be offered to the patient depending on her age, her future fertility, and her desire. What are the key points or take-home message? These endometrial polyps. You remember what are endometrial polyps? These are the projections of the endometrium inside the uterine cavity or the endocervix. These endometrial polyps are common, usually benign focal endometrial lesions. They cause heavy menstrual bleeding, intermenstrual bleeding, and post-menopausal bleeding. Surgical removal, that is polypectomy, either by DNC polypectomy or by hysteroscopy under direct vision as an outpatient or day case. This is the best treatment option for the endometrial polyps. While adenomyosis is a disorder in which endometrial glands and stroma are found deep in the myometrium. So what will happen? This stroma and glands, they will respond to the cyclical changes of in the endometrium due to this estrogen and progesterone, and they will respond. So during menstruation, there will be hyperactivity, hypersecretion, and there will be menstrual blood collected in these glands. So lakes of fluid, they will be seen during the menstruation phase. So due to this lakes of blood in the myometrium. They cause severe dysmenorrhea, they cause heavy menstrual bleeding, and it will also lead to the uniformly enlarged uterus. So this is adenomyosis. Medical treatment like Mirena, that is levonorgestrel intrauterine system, can induce amenorrhea, it will cause endometrial atrophy, and will alleviate the symptoms associated with this disease. Hysterectomy is the only definitive treatment for adenomyosis. So, when the patient is multiparous, she is above 40, she has completed her family, and she has distressing symptoms of adenomyosis, then the best treatment option is surgery, that is hysterectomy for her. So these are the take-home messages. So if you have any questions, you can ask. I'm here. You can ask me any questions if you have.